Hello, and welcome to the next in the series podcast, Let's Get It Straight. Today's topic is going to be tuberculosis update, the why and the what in the new CDC guidelines for testing and screening healthcare workers for tuberculosis. I'm Katherine West, infection control consultant, and I am pleased to help bring some clarity to some of the confusion regarding testing of healthcare personnel for tuberculosis. So let's go ahead and get started. Tuberculosis is a disease that has been around for centuries. It also has been noted to be a cyclic disease, meaning that it appeared that every 30 to 40 years there was a noted increase in the case numbers of tuberculosis. But then, noted without any medical intervention, those case numbers would start going down at about 5% per year. Now, our cases in the United States declined from 1953 to 1984. Now, 1953 is important because that was the year the Public Health Department was given the responsibility to track TB cases in the United States. Between 1953 and 1984, we saw a steady decline. And then the case numbers leveled off in 1985. Between 1985 and 1990, there was an increase noted. Over 23,000 cases were reported in 1990. And that was an 18% increase over the number in 1985. Now, there was something very significant going on in 1985 that you may remember, and that was AIDS. Now, many patients with AIDS had a form of TB, but it was not communicable to us. It was called atypical. But those case numbers were counted with the normally occurring communicable form of TB as well. So I think that's an important point to mention when we're looking at what happened with the numbers. Why, boom, all of a sudden, 23,000 cases, 18% increase. 4 states appear to represent the highest case numbers for tuberculosis in this country. Over 50% of reported cases are in California, Florida, New York, and Texas. Another question, what do these 4 states have in common? Well, they're entry points into the United States. That's what they have in common. If we look at our case rate from 1993 to 2019, you will see a very noticeable decrease in our case numbers during this time frame. That there has been a real effort to bring down the case numbers for TB and hopefully eliminate this disease in this country. If we look at case numbers by race and ethnicity between 2010 and 2019, the highest group for TB remains in the Asian, Pacific Islander, and Native Hawaiian population groups. Not Hispanic, which is what most people automatically respond to when the question's asked. A bit of a surprise. Now, what happened to really begin bringing down the case numbers was instituting direct observed therapy. This is where patients with TB are cared for in their homes. They're not hospitalized anymore for routine care. And the health nurses are charged with delivering each and every dose of their medication and making sure that they take it, ensuring compliance. Well, I'm sure you can imagine that this was staff intensive and a costly way, but effective, to bring down TB cases. Now, in the past few years, some pilot studies were undertaken to evaluate options that might be just as effective and also be cost effective. So, the pilot study showed to be a great success and will now be how TB patients cared for in their homes will be monitored for compliance with drug treatment. They will be given a cell phone. Each and every patient will be given a cell phone, and the nursing staff will monitor them taking their medication using FaceTime, putting new technology and using it for a different purpose and bringing down cost and still ensuring compliance. Now, tuberculosis is caused by a bacteria, and this bacteria dies when exposed to light and air. In times past, people who had TB were sent to sanitariums that were located up in the mountains, fresh air, sunshine, and new cities cropped up called wellness cities. Albuquerque, New Mexico, Colorado Springs, LA. Come for the sunshine, come for the cure. And it's important to note that TB is not a highly communicable disease. You will not find that in any medical textbook. All studies show that it's not highly communicable. So our risk groups for TB are, as we mentioned, foreign-born persons primarily. We also have outbreaks in our incarcerated population, our homeless population, and then, as I mentioned earlier, in our HIV positive population. Now, you see a photo of Ellis Island. Well, Ellis Island was the entry point for all immigrants coming into this country. At Ellis Island, they got physicals, and if they were not healthy, they were hospitalized on the island, treated, and when they were better, they were permitted to enter this country. Well, it closed in 1953, and that's when the Public Health Department was given the responsibility to take over the testing and monitoring of TB cases in the United States. There are actually three types of tuberculosis: typical, communicable form, pulmonary, or laryngeal. That is what could potentially pose a risk to healthcare providers. Atypical, the type that was contracted among the HIV positive population, but it was not communicable to others. And the third type, extrapulmonary. For example, TB of the bone, TB of the bladder, not communicable, not a risk to healthcare workers. Now, what about transmission? Transmission of TB depends upon how much bacteria that person is expelling, the environment in which an exposure occurs, the length of the exposure, and the strength of the tuberculin bacteria. So in general, I think the best definition that I have found to describe an exposure follows this: 2 to 10 hours in a confined, non-ventilated space with an untreated, infected person. 9 out of 10 persons exposed to someone with active TB do not become infected, that they are protected by their immune response. So transmission, as we've stated, most persons who are exposed do not become infected. Close contacts were more at risk: household family members or co-workers. Only 10% of persons with a positive TB test will ever go on to develop disease in their lifetime. It's important to be aware of signs and symptoms to look for when we're doing a patient assessment that might suggest that the individual could possibly have TB. That begins with a productive cough that has been present for more than 3 weeks. And along with that, 2 other signs, symptoms listed on this slide: coughing up blood, loss of appetite, and weight loss unrelated to dieting, weakness, fever with heavy night sweats, hoarseness, and chest pain. So 2 of these, plus the presence of a productive cough for more than 3 weeks, would be suggestive of TB. Now, OSHA has been enforcing the CDC TB guidelines going back to 1993. They even published a compliance directive to make that abundantly clear, and that was compliance 02-02-078. And then the CDC presented us an update on May the 17th of 2019. So how did changes come about? Well, there was a search of the literature, and between 1995 and 2007, data showed that healthcare personnel were at no greater risk than the general public for contracting TB. The data search was a review of 1,147 literature citations, and 39 of the studies focused specifically on the risk to healthcare personnel. And it was found that on new hire screening, a very low percentage of healthcare workers tested positive. So review of the literature, looking at exposure numbers collected by OSHA and the CDC, all come together to be reviewed. And all the evidence here was reviewed by the National Tuberculosis Controllers Association, a CDC work group, and the Guide to Community Prevention Services. These came together as a group to review all the literature and make recommendations for change. And those recommendations, as I said, came out on May the 17th of 2019. Now, healthcare personnel that have a positive history of previously testing positive. So they're coming to be hired by your department, and they state that they have a past history of testing positive. But they have a negative chest x-ray. They do not require a repeat of a chest x-ray unless they present with signs and symptoms suggestive of TB. If an employee tests positive for the first time when they have a baseline as part of their hiring physical, we're to do a symptom evaluation. They would get a one-time chest x-ray, which most likely would be negative. Now, NFPA, National Fire Protection Association Standard 1581 for infection control and 1582 with addressing health and safety have some outdated statements on TB testing. Persons with a history of a positive TB test on previous testing, no chest x-rays are needed. They are given a questionnaire, and that actually goes back to 1994, and then more strongly reviewed in the 2005 CDC Guidelines. So the NFPA guidelines will be updated with regard to TB testing, and hopefully will then be in line with the CDC guidelines, which OSHA enforces, and they also set the standard of care. This is what the new TB risk assessment for new hires will look like. And it's simply asking 3 questions. Number 1, have you temporarily or did you have permanent residence of more than a month outside the U.S. in a country with a high TB rate? Number 2, are you immunosuppressed or is that planned? And question number 3, have you had close contact with someone who had communicable TB since your last TB test? And then this will go in that individual's medical record. So the TB guidelines for 2019 clearly state there is to be no routine, no annual testing or testing at any interval after the higher baseline unless an exposure has occurred. Testing, our preferred method from CDC's recommendations, is blood testing. It is much more accurate and really is cost effective. Blood is drawn on hire. A little bit more blood would be drawn, sent to the laboratory, and you would get back a very accurate test result in 24 hours. There's no need for, as with skin testing, someone to come back to have their test read. If they don't get back in time, it has to be repeated. Very simple. Blood's drawn, result in 24 hours that is very accurate. You know, skin testing, you can continue with it, but it is problematic. And now there are very stiff requirements on who is able to administer them and who can interpret them, that they are now required to have a certificate of additional training with observation checkoff on administration and interpretation. Now, TB blood testing, many health departments across the country are now offering, and you might want to check out availability in your area. If you, following patient assessment, have determined that the individual may be suspect for TB infection, we're now going to talk about the prevention measures offered to you by your vehicle. Number one, your ventilation. You have a rear exhaust fan that exchanges out the air a minimum of every 2 minutes in the back of your vehicle. It's a triple K vehicle specification. Remember to turn it on. Your HVAC system, whether you're using air conditioning or heat, is to be put on the non-recirculating cycle. And then you want to put a surgical mask on the patient. Remember, source control, basic infection control. The EMS approach to looking at risk assessment for your department is, it doesn't matter how many people with TB are being cared for in their homes in your geographic service area. What matters is how many your department transported in the previous 12 months, active, untreated TB patients that your department transported in the previous 12 months. Your department is considered low risk if you transported less than 3 active, untreated TB patients in the previous 12 months. If you transported 3 or more, your department would be described as medium risk. So you're to do this annual risk assessment. It's important because this gives you a proper perspective on risk in your community. This information should be included in annual update training, and it should also be part of the update to your department's exposure control plan. So to review the changes in the updated TB guidelines of 2019, number one, that we are to do TB testing on hire and not again unless an exposure occurs. There is to be no routine TB testing. Number two, that we are to conduct a risk assessment on hire on each individual employee, but we also want to do our community risk assessment so we can put risk in perspective. And CDC wants education and training to be done annually on tuberculosis to keep members of our department informed of what's occurring in our community and of any other new changes that come about. Well, that brings us to the end of this podcast, and I hope we set it straight on TB testing and where it is today. If you have any additional questions after this presentation, please feel free to contact me. You have my office number and my email address. Again, that concludes our session for today. Hope to see you again next time on another Let's Get It Straight podcast. Take care.